Hey, hello everyone. Thanks for coming along for our little clinical psychology consultation session. Good to see a few people out there. Oh, only 3 people. Dearie me. Well, you guys are going to get all the exam answers. You'll be lucky. All 4 people. Hi there. Hi, Christina. Charlie says hi as well. I brought Charlie along today. Hey, Charlie, do you want to say hello to everyone? Come here. Come up here. Yes, you can bring your pink toy. There's everyone. Can you say hello to everyone? Yes. Or are you having a big stretch? Yes, you are. So Charlie has got all the answers to the mind, brain, and behavior to clinical psychology part of the exam, don't you? Yes. So he will be very happy to help today. This is Pink Puppy. We like Pink Puppy. We can put food in Pink Puppy. Pink Puppy, there you go. Charlie has Pink Puppy. He's got, what have you got on your foot? Purple Piggy. You've got Blue Piggy as well, don't you? Yes. Yes, we've got a few toys. But he particularly likes Pink Puppy at the moment. Hi, everyone. Hi, Grace. Where are you going? You're going under there. Okay. So the way in which this can work, well, I suppose it can work in a few different ways. I have got the exam in front of me, believe it or not. I'm looking at your exam. So I've got a good idea about what questions I'm asking you in the exam. And to tell you the truth, you've already got a pretty good idea based on the types of practice questions that I've released about what I'm going to be asking you in the exam. But I suppose just like any other consultation session, in this particular session, you cannot see the answers in the reflection of my glasses, can you? Holy hell, that's not a thing. No, you can't, can you? Well, I'm going to minimize that just in case. You're freaking me out now, Susuf. Freaking me out. All right. So, I mean, this can work any way, but the idea generally with a consultation session is that you would ask me some questions, and then I can provide you with answers. And maybe seeing this is the first time that we're trying this, it might be a little bit rough, but we can just give it a whirl and see what happens. So I'm just going to go through to Canvas and our lectures. And so we've got ten lectures altogether for clinical psychology. The last lecture, well, I should say, we've got 10 lectures. The last lecture was that live streamed lecture from Sane Australia, where I sat down with Sandy Jeffs, the Sane Australia lived experience ambassador, who talked about her experience of schizophrenia. we won't be examining that particular lecture. That was really more for your, or just really to enrich your learning. So we won't examine that one, but we will examine the previous 9 lectures. So if you've already been studying, I suppose this really hinges upon being able to raise questions for discussion based on what you've been reviewing from those lectures, or things that you didn't understand, or things that you remember where you had a problem grappling with the concepts at the time. Now would be the time to think about asking those questions. And maybe while you're thinking of a question to ask, I'll answer Grace's question here, which is a little bit more broad, about future psychology subjects if you're not a psychology major but interested in psych. So the first year of psychology, which you've just done at least half of, and for some of you, what are you doing, Charlie? For some of you, you will have completed Mind, Brain, and Behavior 1 as well. These subjects were very broad. They had lots of topic areas, and we only dug down to, I suppose, a limited amount of depth. There's only so much detail you can go into in the space of, for example, the time that we had together with clinical psychology. But what you'll find in the future is that each one of the topic areas that were covered in Mind, Brain, and Behavior 2 will be picked up and explored in greater detail in future years, where there'll in fact be an entire subject, a semester-long subject devoted to just one of the topic areas. So, and clinical psychology is a good example again. So the third year psychology program has a subject called the Psychopathology of Everyday Life. And it's called the Psychopathology of Everyday Life because this is also what Sigmund Freud called his first book. That was the title of his first book. And the reason he called it this is because he was talking about this observation that the type of psychopathology, the types of psychological problems that he was seeing in clinical practice, in his practice, he was also seeing in other people who were not in therapy, in much more subtle forms. And so Freud was really talking about this idea of a continuum of psychological experience, and not distinct states of wellness and unwellness, there being this more of a continuum in his mind. And you will know that this is something that I'm big on as well. I like talking and conceptualizing mental health and mental illness along a continuum, rather than thinking about these states categorically. You are just so beautiful. Yes, you are. And that's just one of the, that is just one of the subjects that we offer that are extensions and dedicated explorations of the topics that you are covering in Mind, Brain, and Behavior 2. So the Psychopathology of Everyday Life goes on to explore mental health and mental illness, and again, from very much a dimensional perspective, and gives us an opportunity to really think critically about some of the issues that we've just scratched the surface of with Mind, Brain, and Behavior 2's clinical course. And that's just one example. So if you think about social psychology or personality psychology or research methods or developmental psychology, each one of these topic areas have their own semester-long topics that come up later on in the degree. And so that's really the difference between first-year psychology and every other psychology subject that that is in the psychology degree in second and third year, is that they are more focused. They're more focused on one of those topic areas. I hope that helps, Grace. Christina, thank you for your question. Oh, yes, we've got a question. Excellent. Okay, so in the lecture, it says threats to the internal validity of a clinical trial include any factors that may completely or in part explain the relationship between the independent variable and the dependent variable. That's right. So when we're doing a clinical trial, you might recall I talked about there being this tension, a tension between internal validity, which is the degree of confidence that we have in the direct relationship between the independent variable and the dependent variable. And typically in a clinical trial with an independent variable, we're talking about a therapy of some kind, some type of intervention. It might be a medication, it might be a psychotherapy, a talking therapy. And the dependent variable is the level of symptomatology, generally, the level of symptoms. And what we want to see, if we are going to make a determination that the therapy is effective in treating symptoms, we want to see the data fall out such that we do see a direct relationship between the IV and the DV. And in setting up our research project for that data to fall out in that way, we have carefully created conditions that control for a range of other things that could influence that relationship. So, for example, if we were sampling, if in our recruiting of participants for the study and the allocation of those participants to groups, we accidentally allocated males to one group and females to the other. Just say we had a treatment group who was going to receive the treatment, and this was a treatment for depression, for example. And we had a control group that was a wait list control. So they just went on a waiting list, and everybody in the treatment group were female, and everybody in the control group identified as male. And then we looked and we found that our intervention seemed to work, and scores on our depression measure were lower for our treatment group than our control group. We've accidentally ended up in a position where one's identified gender could be a potential explanation for the data, and could, in this case, threaten the relationship between the IV and the DV. Could this extraneous variable of gender actually be responsible for what's happened in our results in any particular way? And one of the key ways in which clinical trials will get around this problem is through that, oh, poor Charlie, is through that random allocation process. So by randomly allocating people to the treatment and control group, we should, in theory, be able to control for issues like gender or age or a range of other things. Theoretically, in that randomness that's involved with the allocation process, these things should fall out with equivalency most often across the groups, and you would still run your checks, of course. So with really tightly controlled, randomized, clinical controlled trials, we see lots of those tight controls, lots of measures taken, lengths gone to ensure that there's not a range of other things like age or gender and so forth that might otherwise explain the findings that we are interested in. We are getting a pure view of the therapy in theory in a really tightly controlled trial when we have a manualized, sort of therapy has a manual for its implementation, and the very small therapy team is supervised by a senior psychologist, and they've gone through a process to make sure they're applying the therapy in the same way, and they go through that recalibration process on a regular basis. Everything is there's lots of careful checks and balances. In contrast, in a pragmatic trial, a real world trial, when you don't have those checks and balances, you'd be looking at how well that therapy that's been established to have efficacy in a randomized controlled trial, how that works in the everyday real world setting where there are a range of factors that could influence your outcomes. There would be less confidence in the direct relationship between the IV and the DV, the treatment and the symptomatology. You'd see lower effect sizes in your scores when you run pragmatic trials when compared to randomized controlled trials, just because there's all of those real world factors, different types of therapists not doing the therapy in a completely manualized way, maybe introducing other things, other historical artifacts, and a range of methodological issues can interfere with the process, but in doing so, give you a picture of how the therapy does actually work in the real world where the constraints are off. And so tells us about effectiveness, we would say, how effective the therapy is in the real world, and supports our ability to generalize our findings to other comparable settings. And so we've got sort of strengthened external validity in that case, quite often we'd say. And that's why we like to look at both those evidence from both randomized controlled trials and more pragmatic trials. And if we can find evidence from both of those areas speaking to a certain therapy being effective, then we would have some confidence in the therapy. That's a really long answer. I hope that helps. I hope that answers your question. Oh, good, good. Excellent. So, what other types of questions do we have out there, folks? I understand that probably quite a few people have tuned in and maybe haven't been ready with questions. this might be a new, please fire as many questions as you like, Christina. So everyone, I understand this might be a new sort of, not concept, but a new way of doing a consultation session. But the idea is very much the same. So I'll do another one of these as we head towards the exam. And so maybe when we're getting towards the exam and you're studying a little bit more intently for mind, brain, and behavior too, then you might come along with some more questions and we can really get into nailing those. So Christina, you mentioned here bottom-up influences. Are we talking here about sensory processing? Is this from the hallucination lecture that you're referring to here, this question? I think that's the only sort of area in which I've talked about hierarchical information processing or sensory and cognitive processing. So the basic idea is that if we go to the level of the mind and we think about how information is processed by your mind, then we would be thinking about a hierarchy of complexity of information processing. And that information processing, when we collect information from the external world that comes in through our sensory organs, yeah, okay, in the hallucination lecture. That's good. Thanks, Christina. So the information coming in from the external world via our eyes or ears or tactile sensory organs and so forth, we think about this as incoming information in its lowest sort of level of complexity, quite simple in its original form, and it is refined and other information is added to it, and things, as we go along the chain of processing information, things become more and more complex. So we think about cognition and information processing generally in terms of this hierarchy, where we have lower order or sort of bottom level processing in terms of processing of sensory information, so fundamental processing of auditory information, so for example, the tone of my voice that you're hearing right now, that's made up of a range of auditory cues. And at the outset, your basilar membrane, your cochlea, they are deconstructing fluctuations in air pressure that are being passed on through your tympanic membrane as they hit your eardrum. And sorry, this is my life. So many messages, so little time. And these very rudimentary signals encode things like the frequency of sound, the amplitude of sound, and the silent pauses in between sound and the times when sound is on. So we're processing sound over time. This is all encoded in their very rudimentary forms. And then we see at a higher order these elements of sound like amplitude and frequency and sound over time, they become combined and they contribute to the experience that you're having of listening to my voice right now. The layer of perception, the experience you're having right now, we typically tend to think of as being somewhere in the middle. It's receiving bottom-up driven inputs from sensory organs, but we know that perception is also your experience of the world right now in terms of what you're hearing and seeing and feeling. all of these experiences are not only affected by what's coming in via your sensory organs, but also by higher order cognitive processes, more complex cognitive processes like memory and like expectation. So based on your previous experiences, what do you expect something to be like? That's a big one. And when expectation becomes overactive, and it can become overactive theoretically because of impoverished sensory input, then we start to see perception might become anomalous. It might start to be more heavily influenced by what you expect to happen than actually what is happening. And so, interestingly, when we look at psychosis and hallucinations, we can certainly draw links between those experiences and problems with sensory processing, so problems with bottom-up processing. And then when there's not enough input sort of coming in, those top-down processes start to become overactive and biased towards predicting, maybe more than they normally would. And we start to see perceptual experiences occur that are not maybe reliable indicators of what would be generally agreed upon to be happening. So that's I hope that one helps, Christina. Ash, do we need to remember the statistics for different disorders? Not really, no. I would just remember the general theme. So there's some disorders that I talked about, for example, where I did emphasize a particular prevalence trend. So I certainly talked a little about the prevalence of I've talked about the prevalence of schizophrenia as a function of sex. We talked about this idea that males have a slightly earlier average onset time than females. So they're typically late teens, early 20s for males. And we also see an onset spike there for females, but then we see a later life onset spike for females as well. So on average, it turns out that males have a slightly lower age of onset on average than females. So that might be one to remember. Can't remember if that's in the exam. It might be. So Christina, yeah, so in that example that I gave regarding the top-down and bottom-up processes, when we're talking about bottom-up processes involved in hallucinations, we're talking about sensory impairments. So you'd also remember that I talked about examples such as people being in solitary confinement, in sensory deprivation type settings, people in whiteout snowstorms or pilots flying at night. We know that under all of these conditions, when there's less sensory information coming in, we can be prone to hallucinate. And that's for a number of reasons. But I suppose the contribution here from a bottom-up perspective is that less meaningful information is coming in, or it's coming in a problematic way. So some of my previous research in schizophrenia has looked at auditory processing for people who hear voices, and we find that they're unable to process things like pitch and loudness or frequency and amplitude in sound, as well as people who don't hear voices. So there's problems with that incoming sensory input. That's the bottom-up question. That's what we're talking about there. So I hope that helps. Will there be more multiple choice questions for clinical psych? Not that I will be releasing. I've tried to release a set that gives you a very good flavor of what to expect. However, you will hopefully work with your colleagues in peerwise to generate examples and test each other through making your own example questions. And we know that's a great way to learn. And the next question from Nee here. Hi, Nee. Do we need the Z table and the T distribution? No, you don't. There's not actually anything on the exam that really needs calculating. There's one question that's sort of calculator-like. Like you might think that you need a calculator for it, but you actually don't. Let me just have a look through the exam right now. Yeah, so there's one question that on the face of things, you're going to think, Chris lied to us. He told us we didn't need a calculator, and we do. And, you know, by all means, bring a calculator if you want. If you want a safety blanket, do. But there's only one question that looks like you might need a calculator, but actually it's more of a logic question. And if you read it carefully, and you know your stuff, you will be fine. Let me just have a look at the exam here again. Oh, that's a mean question. How did I put that in there? What? I'm just kidding. You'll find the research methods component of you'll find the entire exam to be very fair, and certainly the research methods component of the exam is very fair. Nothing too scary in there at all, to tell you the truth. That's a pretty nice and accessible research methods exam. It's just here. It's just here. So, Christina, a hallucination-like experience is generally, when we talk about hallucinations, we're talking about just a complete intrusion on your experience of the world, something that is, for all intents and purposes, as real as veridical perception, but it's not. There isn't a corresponding stimulus in the environment. So a hallucination-like experience is a little difficult to define because, again, we're not talking about categorically distinct things here. We're talking about things that vary along a dimension in terms of severity, in terms of intrusion, in terms of how clear and distinct and long they last, and complex, how complex they are, and so forth. So with a hallucination-like experience, it might be like feeling like you heard your name called, maybe in a cafe or something like that, and you might turn around. We've all had that one. Feeling like your phone rang, it didn't actually ring, that sort of thing. Very subtle, very fleeting, maybe illusions, these sorts of just very subtle perceptual aberrations, not as florid or not as clear and intrusive and impactful as hearing a voice aloud speaking to you when there's no one there. Just had to check that incoming email. So much going on at any one time at the moment. So I think probably when I was lecturing and telling you about clinical psychology, I probably told you about my National Stigma Report Card project, which is now up and running. We have had a really successful first week of recruitment there. It's been going gangbusters. And so we've had about, as of this morning, about 1,300 people living with severe and complex mental health conditions complete the survey and provide information about their experiences of stigma and discrimination and whatnot. So that has been going gangbusters, but it's certainly keeping me on my toes. Okay, speaking of stigma, the stigma lecture, it said self-stigma includes direct negative effects and outcomes of stigma. Yeah. Sounds half a bit like public structural stigma to me. Yeah. So in Pryor and Reeder's taxonomy of stigma, they conceptualize self-stigma, or at least in part self-stigma, to comprise the outcomes of public or structural stigma. So that having experienced discrimination, they would say is part of self-stigma, and they would also, it's a little bit messy because it's a little bit circular, I grant you. And they would also classify discriminatory behavior exhibited by members of the public, or so on the behalf of the person who is doing the discriminating, the behavior that is a discriminatory behavior. If I was a member of the public, they'd conceptualize that as part of public stigma. Or if I was an agent in a system, we might think about that as discrimination in a structural or institutional sense. And then for the person who was affected, that aspect of being affected negatively by those discriminatory behaviors that are emitted by structures or institutions or by members of the public, would conceive of that as being part of self-stigma according to Pryor and Reeder's taxonomy. So it's a little bit difficult to tease apart. I would expect that would be challenging. They're very related. And there's so much about stigma that is intertwined and becomes quite circular. So, of course, Pryor and Reeder also talk about public stigma as being the driving force behind the other areas of stigma, self-structural and stigma by association, according to their taxonomy. However, if you follow the possibilities far enough and you start to consider things like media reporting, news reporting about violent crime, which can quite often pair violent crime with experiences like schizophrenia, for example, then you're talking about sort of institutional structures and stigma and discrimination in those structures affecting public stigma. So public attitudes, of course, people in the public consume mass news media. And so then it starts to get circular, with structural and public stigma feeding each other in some instances. There you go, Charlie. I hope that helps a little bit. So it is a challenging area, Ash, I grant you that, but hopefully that teases it apart a little. Is there an answer for the multiple choice research methods questions given on Canvas? No, there's not. And you know why? That's because some of those questions are going to be on the exam. And some of those questions are going to be very much like some of the questions on the exam. And then there's quite a few that are not like anything that's on the exam. But I've just really given you textbook references there to guide you to answering them. But you could certainly take those questions, take them over to Peerwise if you want to propose answers. I didn't put them in Peerwise because I didn't want to propose answers, but there are certainly questions in there that are the same as questions on the exam, and some that are the same, except maybe I've changed a few words or changed the example, but it's basically the same question. And then there's completely different ones. So that's why I haven't given the answers. And that's the same with Yoshi. So of course, Yoshi's put up, I think 60 questions, and his exam questions are going to come out of those. Or at least some of them, at least some of his exam questions. I think probably quite a few. So Madeline, yeah, so there weren't research methods lectures per se, but there were, of course, the 6 modules and then the three practical classes. You should be treating each one of those, I suppose, as their own standalone class and studying for each of those. So everything in the modules and everything in the practical classes presented for research methods are examinable, certainly. And so as I look at the exam right now, I can tell you there's quite a few in the research methods, quite a few conceptual questions, like what is this concept? Like, what is the null hypothesis? I don't know. That might be on the exam. It might not. I might be looking at it right now. Maybe I'm not. But I'm just saying that's an example. What's a null hypothesis? What's an alpha level? Etc., etc. All of these sorts of things. So know your concepts. Definitely know your concepts. And really, that's my aim for you guys for first year. If you can come away with a conceptual understanding of what we're doing, then fantastic. You know, what does a single sample Z test do? What does a T test do? Can you read SPSS output? Can you read a box plot? Can you read a table? What do you need to look at in SPSS output to determine if stop looking at my glasses, Ash. To determine if you know, there's maybe a significant difference between groups on something. How do you interpret a scatter plot to determine if there's a correlation or likely to be a correlation? And can you read a scatter plot to determine the direction of a correlation and so forth? So there's going to be a mix. And with the research methods, there is only 20 questions. Every other component of the exam has 25 questions. So there's 120 questions in total on this exam, with 25 coming from clinical, 25 from developmental, 25 social, 25 personality, and 20 research methods. And to answer your question, Christina, they are in the same sequence as they were presented in the course, sort of. So clinical comes first, then developmental, then social, then personality, and then last is the 20 research methods questions. Yeah, so Cummings' theory, Christina, he was thinking about elements of auditory processing that rely on things like pitch and loudness and processing sound over time and so forth. And so he was talking about things like speaker identity, speaker identification. So the reason that you can listen to me right now and you know that it's me and not somebody else is because you've heard me before, you know the tone of my voice, and being able to actually decode the tone of my voice depends on your ability to be able to process pitch, loudness, sound over time, and so forth. So Cummings' theory was that if you couldn't process these cues, essentially, you're not going to be able to identify a speaker. You won't know who a speaker is. You're more likely to make errors about a speaker. If you can't process loudness information and sound over time reliably, you're not going to be able to identify where a speaker is in three-dimensional space. So you're not going to be able to source locate the source of sound. You won't be able to tell where it's coming from. And when you think about the experience of auditory verbal hallucinations with the experience of hearing a sound or feeling like you're hearing your own thoughts maybe, or a voice outside of your body somewhere in three-dimensional space, or maybe even hearing another voice inside your own head. Basically, Cutting was putting forward this idea that if you can't do all of these prosodic or these elements of processing that are over and above any sort of basic language processing or processing of the words in speech, if you can't reliably tell who's speaking to you, where they are, whether they're happy or sad, whether they're sarcastic, you can't get that extra layer of information apart from the words itself, and you can't process that, then more than likely you're going to misattribute sound or internal experience of sound, maybe recollection of an auditory memory. You're going to be more likely to attribute that experience to an external source by mistake. Glad that helps, Nee. All right, so we've got about 10 minutes left. What are some other burning questions that we've got? And we will schedule more of these, but this is a good first opportunity to do some questions, right? I can tell you that for research methods, you'll need to know how to interpret output, box plots, scatter plots, descriptive tables, and know some of those conceptual questions as well. Definitions. So think about all of the things that we've talked about. Like what does a t-test do? What does a correlation do? You know, what's the important part of a Pearson's R to remember? Is it the size of the R? Is it direction? Is it whether or not it's statistically significant? Is it all of those things? Might be something to remember. And the clinical psychology section, again, you know, spread your study across the lectures quite evenly, I suppose, would be my recommendation. Of course, our first lecture was all about, you know, what is clinical psychology? What's the model of training clinical psychology? You remember that Boulder model that I talked about, which was that conference back in the 40s where everybody that was a leader in the field got together and they talked about what is going to be the model for training in clinical psychology, and they worked out that there would be equal weight given to science and practice in the training of clinical psychologists. And so clinical psychologists learn to be scientists and practitioners. That all goes back to that Boulder model. And then we went on to talk about how that plays out in terms of training and the pathway for training in Australia. What's the difference between a neuropsychologist and a clinical psychologist? What's the difference between a psychiatrist and a clinical psychologist? And so forth. And that were probably the main points I can recall from the very first lecture, or I think we talked in passing about ideas that are still really important at the opening of the lecture, those general mental health and illness facts, like the idea that physical disorders, physical conditions and medical illnesses can give increased risk for mental disorder and so forth. Psychological health problems can increase risk for physical health problems as well. And then in the next lecture, I think, we might have got into stigma in the next lecture, but then we got into classification more broadly, thinking about some of the core challenges in classifying mental health problems and determining what might be an issue and what might not be an issue. And we talked about those ideas around statistical deviance, or things that are infrequent. Maybe you could classify mental illness from that perspective, or things that were a cultural norm, or things that violated a cultural norm, I should say, or things that caused distress. And we sort of looked at each one of these angles one by one and determined that you couldn't really meaningfully make a determination about what constituted a mental health issue and what didn't based on any one of those things. But in combination, maybe you would be getting closer to a meaningful way to approach understanding, classifying, assessing, and treating issues where there's help required. And we talked about Jerome Wakelin, I should say, sorry, and his harmful dysfunction analysis of mental disorder, which required that there's both harm occurring for the person and dysfunction, and that a naturally occurring psychological mechanism isn't performing the way in which it should. Question here, Madeline. Hi, lectures reference quite a few theorists in their background. Am I right in assuming that questions won't test us on memorization of details about the theorists, but on their understanding of the better understanding of the theories. I can't speak for the other lecturers, but yeah, I wouldn't be asking you any particular questions about particular people. So I might say, you know, what we were just talking about, Jerome Wakeland's harmful dysfunction analysis of mental disorder. So if I was going to ask you about that, I'd ask you about that theoretical approach rather than anything about him per se. Yeah. Do you suggest that we do any second or third year psych subjects in the first year? I suppose no, I don't. I think it's better if you put, it depends on your study plan, I suppose, and what you're wanting to do, but I think you will get far more out of second and third year subjects if you do the fundamental study first and then start to scaffold on that and start to see the connections. How you going down there, Charlie? You okay, mate? Hey? Do you have any questions, Charlie? Hey, do you have any questions? Can I have Pink Puppy? Can I have Pink Puppy? What's Pink Puppy doing? Oh, you're under the table and you have to come out first. Here, come up here now. I'll hand up. What are you doing? Oh, you're going to start typing. Is it possible that you can have access to MBB1 lecture slides? Only if you're enrolled in the subject do you get access to the lecture slides, unless we're talking about the research method stuff, and then you do have access to those in the MBB2 research methods modules in there, don't they, Charlie? Yes. MBB1 is going to change significantly next year, as is MBB2. Huge changes that we're working on at the moment based on student feedback and just improving the courses. We always try to improve year by year. And as you know, the Hearing Voices program, for example, that was a big addition to the curriculum this year. So MBB1 is going to change massively next year. There's not going to be 3 lectures a week. There's only going to be 2 lectures a week. The tutorial classes are going to be shorter, but there's going to be more of this sort of thing. So fewer, I suppose, less content. We've trimmed the content down a little bit, and this is going to be the same for mind, brain, and behavior too. Trimmed content, more focused content, and more focus on us working together on some online group-based activities, exploration and application of the content. And this is, I suppose, we're going to make these changes in the first instance in first year and see how students like them, and then based on what we learn from evaluation, we'll take that through the entire psychology course, more or less. So it's exciting times. Exciting times, certainly in first year psychology. Always a lot changing, hopefully for the better. But there is lots going on right now. Lots of people working on changes, and a lot more online interactive interesting content. So I think that's it for today. Glad I answered all your questions there, Christina. I will have a look at my calendar. We'll schedule another one of these. It might be the same time next week. And you can come along with your questions about clinical psychology or about research methods, and I will certainly be happy to answer them. And maybe by then you're starting to think about studying for the Mind, Brain and Behavior 2 exam more. I understand that there's many exams that you have to study for, so and they generally happen in succession, don't they? And that's fine. But we'll be staying in touch all the way through to the exam day, and then I'll be there on the exam day to settle you all in. So this is just the start. Okay. Well, thanks everyone. Hope you have a good day. Don't know what the weather's doing right now. It's off and on, isn't it? But stay warm. It's a bit chilly out there, although I feel like it's getting warmer now. I don't know. Look after yourselves, and I will talk to you. And Charlie has come back to sleep, but we will talk to you again very shortly. All right, everyone. Oh, it's kind of raining now. Yeah, probably. It's Melbourne, isn't it? Every 15 minutes. All right, everyone. Take care, and I'll speak with you soon. Bye now.